Hi everyone, my name is Bridget, and this is my infectious disease presentation on human immunodeficiency virus in pregnant women. About the disease, authors write that globally an estimated 1.8 million children infected with HIV in 2016, and over 90% of infections among infants and children occur through mother-to-child transmission during pregnancy, labor, delivery, or breastfeeding. Currently, the global HIV burden is estimated at 37 million individuals. HIV is a virus that attacks the body's immune system. HIV infection in humans originated from a type of chimpanzee in Central Africa. When untreated, HIV can lead to AIDS. Research notes that at the end of 2016, 1,814 children were living with diagnosed perinatal HIV, and of these 1,139, which is 63%, were Black or African American, 15% were Hispanic Latino, and 11% were white. At the end of 2016, over 10,000 adults and adolescents aged 13 and older were living with diagnosed HIV acquired through perinatal transmission. An estimate for 2006 had suggested that approximately 8,500 women with HIV were giving birth annually. However, more recent evidence suggests that the number is less than 5,000. That is likely because we have made great advances in routine testing and effective therapies. Risks. Engstrom et al. Writes, infections in pregnancy can have more serious sequelae than in non-pregnant state due to the potential for congenital or perinatal infection in the fetus or newborn. Some of the maternal risks. Perinatal HIV transmission can happen at any time during pregnancy, childbirth, and breastfeeding. The mother may require a scheduled cesarean section delivery in order to prevent transmission to baby. The mother can also become immunocompromised from taking the ART therapy, which puts her more susceptible to other infections while she's pregnant and on the therapies. Fetal risks. The risk of transmission from mother to child can be 1% or less if the mother is compliant with HIV medication daily throughout pregnancy, labor, and delivery, and if the medication is given to the baby for 4 to 6 weeks after giving birth. The CDC guidelines explain that taking HIV medication reduces the amount of viral load, which helps prevent transmission to the baby. There is a risk of transmission through breastfeeding, therefore it is not recommended for HIV-positive mothers to breastfeed. Patient presentation. Some patients may present with experiencing flu-like symptoms within 2 to 4 weeks after initial infection, called acute HIV infection. These symptoms may last for a few days or several weeks. Some of the subjective symptoms reported by patients include chills, night sweats, muscle aches, sore throat, and fatigue. Some of the objective symptoms seen are fever, rash, mouth ulcers, and swollen lymph nodes. Other differential diagnosis for the patient presenting may include influenza, parvovirus, hepatitis B or C, or Ebola. Diagnostics. The CDC currently recommends HIV testing for all women as part of routine prenatal care, and in some parts of the country where HIV among women is more common, the CDC recommends a second test during the 3rd trimester of pregnancy. Patients are to have a pelvic examination and be tested for sexually transmitted diseases such as HIV during their pregnancy. Treatment plan. The author writes, maternal combination antiretroviral therapy together with postnatal interventions, has demonstrated its efficacy in substantially reducing the risk of MTCT. Pharmacological. HIV treatment involves taking medicines that slow the progression of the virus in your body. HIV is a type of virus called a retrovirus, and the combination of drugs used to treat it is called antiretroviral therapy. There is no cure for HIV, but ART reduces the amount of viral load in your body and body fluids. HIV medicine should be started as soon as possible following diagnosis and is to be taken as prescribed and without interruption throughout pregnancy and childbirth. HIV medicine should also be provided to the infected mother's infant upon birth. Non-pharmacological. It is important to identify and provide support to patients who are struggling with alcohol or drug use during this time because substance use may interfere with their ability to keep themselves healthy. Mental health services and support groups for mothers may aid in accepting living with HIV. It is also important to routinely assess and conduct necessary fetal well-being tests for the patient infected with HIV. Patient education. Per the CDC, the advances in HIV research, prevention, and treatment have made it possible for many women with HIV to give birth to babies who are free of HIV. The annual number of HIV infections through perinatal transmission has declined by more than 95% since the early 1990s. Medication teaching. Although pregnant women with HIV may have nausea during pregnancy that can interfere with taking medicines, it is imperative that this medication that is prescribed to treat HIV is adhered to. Also, new mothers need to see their HIV medical care provider consistently during this time. It is important to start HIV-positive babies on treatment early because the disease can progress more quickly in children than in adults. Providing HIV medicine early can help children with perinatal HIV live longer, healthier lives. Side effects of ART may include nausea, vomiting, diarrhea, difficulty sleeping, dry mouth, headache, rash, dizziness, fatigue, and pain. ART is usually taken as a combination of 3 or more drugs in order to have the greatest chance of lowering the amount of HIV in your body. It is important as providers that we educate our patients regarding encouraging and using proper safe sex practices, including barrier methods, in order to not spread the incidence of this disease. Patient follow-up. ARTs put patient at risk for myopathy, cardiomyopathy, neuropathy, lactic acidosis, or fatty liver. It is important to monitor liver function tests, liver enzymes, hemoglobin and hematocrit, and platelets. All HIV-infected women should also be tested for hepatitis B and C. Patients that are on stable antiretroviral therapy regimens should have their viral loads checked each trimester.